if we do a motion device, is it going to decrease the pressures on those adjacent levels? If we get to it a little earlier, which we don't really even talk about yet, but that's what happened with hips and knees, is the age started to go down because you didn't want to wear out your other joints. And so now, having a couple of decades behind us, we're seeing, real advances in innovation, but in some ways it's like trying to make a better horse and buggy, in that you're trying to make the buggy roll better and the horse run faster, but it's not the best answer. And that's where I think we are right now, is that we're trying to do fusions better and better, which is the intent of that is good. But the real answer is to replicate normal motion as best we can.
Welcome back to the Spine Pod. This is something I'm so excited about. We are doing a founder series.
We're doing a founder series. We've talked a lot about this, right? And you heard in our first episode that we're going to be doing some new topics, some new concepts this year.
Yeah.
And so one of the things that we talked about is being in the middle of it. How do you get products to market, right? Mm-hmm. And what does that process look like? Because I think a lot of the times you see what's at the end of the road, but you don't see what's at the start, right? Mm-hmm. Or what's in the middle. And it doesn't take 5 years. It doesn't take 10 years. Like it can take so long, and there's so much that goes into it. So we were super excited to share this, and we have two of the perfect people to talk about that with.
Perfect
So
people.
We get to start off and right away in season 2 here, have a founder series and talk about how a product actually goes through that life cycle and what that looks like when it starts and when it ends, because it's not always the same, right? So I think we've been looking forward to doing that for a long time, and we found the right time. So we're really excited to share that we are doing a founder series. So to be able to sit down, we got to sit down. The first part of the founder series was Dr. Craig Humphreys, and we actually went up to Alaska for that.
Soldotna, Alaska. It was a journey, the last frontier. It was so much fun. We got to sit with him in his home. We got to spend time with him and his wife, Julie. It was amazing.
Absolutely. Well, he's such a special individual, right? Obviously, he's well known in clinical practice in the spine community, but just a down-to-earth, humble individual. Both him and Julie are the same exact way, right? Believe in the same thing, have the same passions, and they've been able to push a lot of the work that they have forward because they have those same ideals, right? And they're really trying to make a difference. So to be able to sit down with him and hear his story in the place where it all started, right? This started on the Kenai River. And now we get to go back to the Kenai River to share this story.
Yeah, absolutely. So we're talking about Modus, lumbar total joint replacement, which was co-invented by Dr. Craig Humphreys and Dr. Scott Hodges, who will be part 2 of this founder series. So 3Spine is the company that this lives under right now. And the device is currently finishing up the data collection phase in a U.S. clinical trial. So we're going under the hood. We're saying, how did we get here? And we're talking to the 2 people who know it the most. And so it's been so fun to get to sit down with both of them.
Absolutely. You get to hear the story, and Dr. Humphreys talks about it a lot, about how things happen at the right time with the right people for the right reasons. And that is the story that you get to hear over the next 2 episodes. And a lot of it comes down to having the right people in the right places,
Absolutely.
right? So you hear about Dr. Humphreys and then Dr. Hodges, who they both drive this parallel journey to bring this thing forward, right? And then you hear about other people, right? Mark Peterman comes into the fold, and we've sat down. Everybody here knows very well Dr. Pat Warden,
Absolutely.
right? A very critical component of this. Yep. And then Dr. Louis Nell, who we'll hear from as well, and we sat down with at NAS. But how all these integral components come in at the right time, and you got to kind of get to hear that story, right? Of why that's so important, why those people are so critical at the junctions when they come in, because it's not easy, right? It takes a lot of time. It takes a lot of work. And everybody that's been part of the process, I mean, their heart and soul is poured into it, right? It's not a couple-year journey. It's been 20 years since the inception of this thing.
Absolutely. incredible. And so kind of diving into Dr. Humphreys and the conversation that we got to have with him, sitting in his living room, like you said, the Kenai River behind us, which is so unique because Modus, lumbar total joint replacement, was originally called the Kenai Device because of that river. So it was really special to get to go back to that place and sit down with Dr. Humphreys, who is just such a wealth of knowledge, such a down-to-earth person. And he provides such good balanced perspective on where spine care has been and the importance of motion preservation and why he is so passionate about driving Modus forward.
Absolutely right. And you look at this side of things and what he's done with Modus, but then you look at all the philanthropic work that him and Julie have done as well. So you look at the Carolyn Jane Foundation and everything they've done for pediatric and scoliosis work in Africa. And it's just incredible, right? And we talk about this a lot, right? Their faiths are aligned and their passions and their ideals. And that's how special things happen, right? Is they've poured so much their time and their effort into these. And now to be able to start up a fellowship program, right? And they've done housing, but just, you know, it's not like he's short. He has a bunch of extra time on his hands, right? Him or Julie, right? And so to be able to see all the work that they've done outside of this and all the people that have come together to make it so special and so powerful. I mean, I'm grateful that we got to be part of it, that we've been able to be part of it over the last few years, and that we get to share this story and got to share it in the place that we did. So I think it's a really exciting episode, and I'm really excited to share it.
I agree. So enjoy looking under the hood in this episode with Dr. Craig Humphreys.
Dr. Humphreys, thank you for taking the time for sitting down with us today.
Thanks for coming all this way. Really appreciate it.
We wouldn't be able to do it if we didn't have somebody to host us in this fantastic place. So thank you so much.
We're sitting in your house in Soldotna, Alaska. So quite a trek to get here. And we were just talking about you come and visit us in Chattanooga a lot. I'm like, whoa, we didn't realize what a journey you're constantly having to take. It's quite a bit to get out here.
Yeah, it's kind of like the true trains, planes, and automobiles to get here, but it's beautiful. So that's kind of takes up some of the time, and you know, it's an enjoyable trip if you don't get stuck somewhere. So.
Absolutely. Well, we've been waiting for this one for a long time to be able to sit down with you. Obviously, we've been very fortunate to get to know yourself and Julie over the years. And, you know, we've been very fortunate for that. But, you know, just your story and everything that you've meant to us and the spine community has been so impactful for us. You know, so we're sitting down here with one of the founders of the MOTUS device, which was, you know, long ago, the Kenai Device and the first lumbar total joint replacement, obviously from 3Spine, and you've played such a big role in that development as well. But then your role just in spine in general, right? So you practiced down in Chattanooga for a while, and then you made your move up here, and you've been practicing for here, you know, the last 10 years or so. And then all your philanthropic work as well. So I think you're such a well-rounded individual in spine. But truthfully, I think one of the first things we want to dive into is what got that all started for you, right? Those things don't happen by accident. And, you know, what was your journey to get to medicine in the first place?
You know, I think everyone's is different. We were talking a little bit earlier about some of the other docs and their interesting stories. You know, for mine, it was I was born on an Air Force base, Eglin Air Force Base. My dad was in the Air Force. But at 6 months, we moved to Iceland, and we still wonder if he was always in trouble because we ended up in Iceland, Alaska, the Faroe Islands. I mean, not your go-to destinations necessarily. But when I was 6, we moved from Iceland here, and this has really been home to Alaska. I grew up in Anchorage, and there my mom was a elementary school teacher, but she did a lot of work in the bush communities, which here is just a word for rural community. There's thousands of American Eskimo and Indian, you know, cultures here. And so a lot of those kids would get behind. And so she really specialized in reading and making sure those kids kind of kept up or didn't fall behind because their backgrounds were different. And so I think that kind of instilled in me that wanting to help attitude. I think the other thing that's kind of really helped me, and it sounds maybe a bit backwards, but when I was younger, I stuttered terribly. I had a bad stutter. My teachers affectionately call me their little broken record, which I really wasn't a bad thing. It sounds kind of mean when you say it like that, I guess, but they always did it with a good way. But it gives you insight into having a handicap. Certainly, there's much worse handicaps than stuttering, but it does give you an insight, of what someone feels like being in someone else's shoes. And I think that's helpful in medicine. So I think, having a family that, kind of was in the service, the service was important to, and then having a handicap really was kind of the impetus of ending up in medicine, though I didn't really recognize I wanted to do medicine until I was in my, fourth or fifth year at Notre Dame. I went to high school here, thought I'd come back and be a marine biologist was really my love. I was a biology major with not an ichthyology, which is the study of fish, minor. But I took a lot of courses and worked with some of the marine biologists at Notre Dame. And I think all the science classes ultimately kind of tipped me toward medicine as I got toward the end of my Notre Dame career.
I was going to say completely unbiased, but you did start your schooling at one of the best universities in the nation. So, right?
Absolutely.
I'm stuck in between both of you, just trying to represent.
But truthfully, right? You started off at University of Notre Dame, and then you couldn't get enough of the Midwest, so you jumped over to Chicago, and you went over to Loyola for your residency program and medical school as well. So, and then you went up to MCW. What kept you kind of in the Midwest? What kept you moving through medicine, and then really what kept you in spine specifically?
I think Notre Dame was kind of a conduit, being a Catholic school, and Loyola, where I went in Chicago, was Catholic, and so that was that was really a blessing. At that time, when I was thinking about medicine, I thought about coming back and serving the rural community. So I pictured myself as a family practice doc or general practitioner with a bush plane, going out and kind of servicing the smaller communities. So I looked at pediatrics initially, and then just family practice. And I think for me particularly, the medical school part of it being in Chicago was helpful. I'd grown up in very rural settings, and at first Chicago was very intimidating for me. But getting used to the city, I still love Chicago. The food is great. The sports, Michael Jordan was there. I just couldn't, after a year or so of the adjustment, I just couldn't get enough of being in Chicago. And the healthcare was great. We have Rush, we have Northwestern, we have Loyola, we have the University of Chicago. And we could go listen to those lectures and be involved in that community. And, as we kind of transitioned to 3-spine, I was broke. I was we always had plenty, but my mom was an elementary teacher. My dad did sheetrock after the military. So we didn't have a lot. So I was looking for a job during my second year of med school. And above the washer and dryer, which was part of what was at the campus, was a job for $7 an hour cutting pressure sensitive film in a biomechanics lab that just happened to be Dr. Pat Warden, who has become a lifelong friend and a mentor. And so I started off watching football on the weekends, cutting film out, not paying much attention. We were doing carpal instability studies, which I didn't know even what a carpal bone was at that point, hardly. But the residents, really, we got along well. And over time, I became friends with a lot of them, which had a big effect on me, ending up in orthopedics and ultimately spine.
And you made the move up to MCW from there, right? Yeah,
I stayed at Loyola for my med school residency. A big part of that was I met Julie, my wife, on the oncology floor as a med student, and so we were expecting our first. So I stayed in Chicago for training, and it was my number one choice anyway. So the residency program, like I say, most of the residents were close to me. And with Julie, my wife, being from the South Side, it just kind of made sense. And then MCW was with Dr. Howard and Lee Riley, who's now at Hopkins. And I think Howard is at Rush now, but he's just retiring this summer. And both of them were great mentors for me. It was a program where I could kind of, I was the only fellow, and I liked that. It was close to Chicago. I worked with a lot of the people in Chicago. Howard had done a lot of cervical. He'd just written a textbook on cervical, and that wasn't one of our strengths in residency. We didn't get a lot of cervical, so that was one of the reasons I picked it. And Howard's a big researcher and I liked research. So it just gave me that ability to write, which I still need work on my writing. It was something I needed work then, and I still need work now, but I enjoy it. But I really enjoy the research part of it too.
And when you talked about this early desire to do kind of covering underserved communities and going from, being a bush pilot and jumping around and doing some of those things, and then your transition to spine, what was it that you saw in spine, or what was it that you started to do that you said, no, I'm going to set my sights on spine and start working there?
Yeah, that's a fair question. Initially, like I say, I wanted to do pediatrics, and as I really liked ortho, I think maybe I should take a step back. I worked a lot with my dad we had here building cabins. You can go out and homestead property still in Alaska. You just go put stakes in the ground when I was a kid, and you can call property your own. You have to do certain things to keep it. But we built a lot of cabins by cutting trees down, cutting lumber from the trees. And so orthopedics, for me, I didn't go to a private school. I went to a public school. And so even catching up in Notre Dame, the academic part, I really had to work. But from the orthopedics, a lot of the power tool part and just the perception of how things would go together, or working with screws and that kind of stuff, some of that was kind of innate because I had done that my whole life. And I think there was a comfort level with orthopedics that there wasn't with some of the other specialties. As far as the pediatric part of it, I love pediatrics. Those are the two things that I went with. And when I went with ortho, our chairman, Dr. Terry Light, who was a congenital hand surgeon, and I thought until my third year I was going to do congenital hand. I really admired him. I liked working with kids. There was a need for it. But when I was at the Shriners Hospital in Chicago, there was attending Dr. John Levicki, who had a big impact on me. And there were several others at the Shrine. The Shrine's just a wonderful place. And they did more spine. They invited me to go on a trip with them to Lithuania. So I went 2 weeks with the Shriners Hospital, and we did scoliosis every day. I was exhausted when I came back, but I loved it. And that was really where my spine journey really kind of began with kids. We had a lot of the guys from Rush. DeWald Sr. was there and was a big person in spine. Dr. Hammerberg was very, very kind to me, was a tough teacher, but I really respected him and taught me a lot. And so the list kind of goes on and on. You don't get to learn that much without other people believing in you, sometimes more than you believe in yourself. And that that's you look back, it's all the people that gave you a hand up. And there's just a lot of them in my journey, particularly coming from here and, not really having any connection to medicine.
I think one of the things that we've talked about a lot too is this is a family journey for you, right? I mean, clearly you're both your mom and your dad have played major roles and still tie into your journey right now and a lot of the things that you're doing. And there's a lot of that I'd like to talk about as we get on here. But once you left MCW, you went down to Chattanooga, which is where I think a lot of this started, right? I mean, there's a big story once you get down to Chattanooga and how a lot of this started and how we truly get to Modus and 3-Spine down the road. So can you talk a little bit about that journey? What, you're up in the Midwest and then you moved down to Chattanooga where you met our other founder, Dr. Scott Hodges. And a lot of this happened. I love the Inception story. So I'd love to hear a little bit of that and how it all started. Yeah, one of my favorite stories.
To be clear on that story, initially we had signed to come to Alaska right after my fellowship. Actually signed with a really close friend of mine who just retired from Anchorage, who was a spine surgeon, Dave Peterson. But my family is originally from East Tennessee, my mom and dad. So they're from Greenville or just outside of Knoxville, kind of East Tennessee. And Dr. Hodges, or Scott, was ultimately my partner in Chattanooga, was doing a fellowship in Chicago and was actually on faculty at Loyola when I was a resident before I went to do my fellowship. And then obviously worked with Dr. Pat a lot. So my wife loving Alaska, but having a few concerns about moving all the way to Alaska away from her family.
She was pregnant. Chicago.
Yeah, she was pregnant with our second child. And she had really sacrificed a lot. My wife's a nurse. She was the breadwinner for most of it. We both worked long hours. We had, our first child and then our second, being a resident's not easy on the spouses at all, even though she was in healthcare. And so at that point, I think it was just too much too fast from Alaska. We loved it, over time, it became something that was much more comfortable, and for different reasons we came back. But Scott and I became friends, and he came down and had a very successful practice initially, was busy, and called me, multiple times. Not that I didn't want to come, it was just the decisions we just had to make as a family, but ultimately ended up there. And he had just a wonderful 15 years in Chattanooga, so...
And he's, Scott's obviously a great operator. We've got to know him very well as Dr. Hodges, and we've gotten to be very close with him. But if he's anything, he's a good salesman. So
He's persistent.
Persistence is true.
Yeah.
Is absolutely true. But so the actual inception in what is now Modus was the Kenai Device, and that came out of Chattanooga around early 2000s.
2002 was the initial design. Yeah.
So can you talk a little bit about the initial design and what that looks like? Because I think it's such a fascinating story.
Yeah, and I think it's probably worth just taking a second and talking about Dr. Pat a little bit too, because initially in residency, and I think Scott was involved in a lot of this too, kind of not with me as much at this point, but we did a lot of the initial burst fracture studies where they dropped 10-kilogram weights and ultimately looked at the different columns of the spine and just we thought through a lot of that, and Dr. Pat came up with a follower load model that was just. Not only did you get to learn about it, but you got to see how it was kind of conceptualized and where it came from. And so I was fortunate enough, and so was Scott, to have a lot of that in the background. When I went to Chattanooga, Scott had been there a couple of years, but initially we got a chance to work with Jürgen Harms, and he had, was describing the T-lift, which was a little new. We did PLIFs at the time. And so you basically, take off the medial part of the facet and then retract on the dura a little harder than you have to with a T-lift, then you get higher bleeding and sometimes more radicular pain after surgery. So after watching him and spending some time with Dr. Harms in Germany, we started working on some T-lift cages, because the Harms cage was great, but it had sharp little edges. It didn't fit well. And so there was some things that we saw on it and was, as far as placing it more safely and that kind of stuff. So we really started working on that, the kind of Camden's triangle area. And so that also kind of led to this. So we developed a cage that ultimately was sold to a company. And about the same time, Charité, an anterior cervical or anterior lumbar disc, was coming onto the market. And we loved the concept of motion, but we just thought the indications were going to be narrow for it. And so that kind of together set the stage for, I think, in our own mind, it wasn't like it just kind of fell out of the air. That kind of, set the stage for, we need motion, but we need an approach that is more of a utility approach, that we can do everything, decompress and everything, but then allows us to maintain motion. That's kind of where the idea was born.
Well, I think it's, it starts so much earlier, just the fact that you both ended up in Dr. Pat's lab. I think there's something, we talk about it at 3 Spine a lot, of there's some magic that has just happened along the way. And I'm excited to hear more of like your side of the story of how we're here today and things that have happened that are just, you can only say it was God or, a higher being that was kind of keeping things moving. But I think that's kind of where it all began, was the fact that the connection of the 3 of you all ending up together and kind of having that as the baseline of your learning and then ending up in Chattanooga together. I just love that. I love that story so much, also because all of your hearts are so similar. And so it's been really cool to see, so many years later, the connection that you guys still have and the passion that you have about just changing the standard of care and learning and evolving. And I just think I'm excited to just kind of dive into those like little magic moments that really have like brought us here.
Yeah, I think over the 22-year span, there's been a lot of times that, I think I said earlier, you have other people have more faith in you than sometimes you do in yourself. And sometimes it might not be other people, it might be other energies and other things. And I think we all tend to be spiritual people in different ways, but we all believe there's a higher power. And so, we've kind of felt fortunate that at times when it looked the darkest, we went to 2008, the tech, kind of exploded and a lot of the companies cut back, and we managed to survive that. Medtronics initially purchased us. And I don't know if we want to step back once we did. Maybe we can step back, but initially purchased us in 2004. And they were doing FDA trials on Diom. They had 2 on Diom. They had done one on Maverick. Had some issues, I think, with patents over the keel. Ones on Diom were hard to enroll. And we were next up. At the time, we were metal on metal. And because polyethylene, has been more advanced since then. So we're able to make it thicker with vitamin E, with radiation. We're able to make it so it's less fragile now. But at the time, we were going on metal for reasons we thought were sound. But with the metal on metal hip kind of thing that happened, we would have been in the middle of a trial if it wasn't for 2008, which we thought was a disaster. But in some ways, we were kind of blessed by that, because if we'd been in the middle of our trial with metal on metal, we would have it wouldn't have gone through because of some of the hip stuff that basically kind of tainted metal on metal.
Let's take a step back a little, because I think the Inception story is really cool too, of the two of you working together and kind of just, if I remember correctly, like you woke up in the middle of the night kind of just with this like click in your brain.
Yeah, that's my wife still takes credit for that. I've never had that happen before, never had it happen since, but I woke up at 3:00 on the dot. I mean, because I had one of those clicky clocks, and I looked over, and it was one of the ones that rotated, and it was lit up, and it was 3 exactly. And I said, Julie, and she was not happy about me waking her up at 3. I said, can you get a pencil and paper? And it's like I didn't want to move because you're kind of sleepy, anyways. And she was she was fine, but she went and got a pencil and paper, and we wrote it down. And I actually got up. I think I went back to bed for a minute, but at that time in our practice, Scott and I had early block time, and we would round about, I don't know, I'm guessing a little bit here, 5 or 5:30 was early. So I wrote down the idea just roughly on a piece of paper that Julie had gotten me, and went in and, just happened to see Scott on rounds. We would see each other a lot, but it was like the instant I got into the hallway, I haven't even started a round yet. And so he and I did a lot of research stuff together and would debate stuff all the time. And I just said, hey, I want to show you something. And that was an unusual time for us to be talking about this. So I'm sure he was kind of wondering what's up. And typically our typical exchange would be something like, whether he's showing it to me or I'm showing it to him, it would be to kind of play devil's advocate, not in a bad way, but it would be, well, I don't know about this, or I don't know about that. Did you think about this? I think it might be the only time I remember him just looking at it and just thinking. I could just see his wheels turning. And Scott's got a really good mind for that kind of thing. And he didn't say anything. I think he either said it then or later. The only thing he said, I think, to me was, I have an artist at a college up in Ottawa. Let me talk to him. And Scott knew someone, and I started having some drawings made, and then ultimately some clay models by one of the artists at one of the colleges, and that's kind of where it started. And then we, kind of went from there. We still have those clay models. We have one, and I think Medtronics may still have the other one, or Mark may have it. But
it's the first thing you see when you come into the office.
When you walk in.
Oh, that's right. It's in there. Yeah, those pictures too. I forgot.
Thing.
That's one of them.
We got it
there's
covered
another one.
in plexiglass. It's safe.
Yeah, that was the first rendition. And that actually, if you look at it, has poly. It's built in 3P. It's the poly's not attached. It's kind of like but we had it attached, but it's made with clay. But it does show metal, polymetal, which is part of our original patents.
But I think one of the things I love about that is the true, talk about a true startup story, right? Like Inception in the middle of the night. And if that's not divine intervention, I don't know what is. Right?
Yeah, I still go back to that, because I've read some stuff about things that come to you at night, and you can theorize it a lot of ways. I tend to come at it from a faith-based, because that's my background. But it is also a time when I think you kind of let your inhibitions down, and it's time when you can kind of think a little more freely, and you're balancing the stuff of the day or things you've been working with too. And so it just all seemed to come together. And I like to believe there was a little push there, and I think Scott feels that way too. Is this something that we've been working on and seen that those kind of things kind of happen over the 22 years, whether it's that or other things that you can't make sense of, but keep allowing us to move forward.
That was going to be my question to you. Hindsight's 2020, but it's a long journey, and it's a lot to take on to try to do what you guys have done. Did you have just a gut feeling? Like, what made you keep pushing? What made you say this is an idea that's worth investing in the way that you had to? I'm really curious, because, we all can have moments like that in our lives, and a lot of times you just let them go, right? And like, when do you decide it's that thing that I'm going to kind of invest in? And, this is a legacy that you both have created now. How did you know to make that decision?
It's kind of a progressive thing. It's not something that at least for me happened all at once, because early on, and I've learned recently, and you guys have heard me talk about it, we're writing some articles on adoption curves. But at the time, I really didn't know much about adoption curves. And everybody laughs at you early on. Because it's it's ridiculous. It doesn't have 3 columns. How is it going to stay stable? But as you study it and stuff, you realize they did with total hip, they did with total knee, they did with total shoulder, they did it with all of, everything that comes, and you have to incrementally kind of work your way through it slowly. And you have to be open, because you have to say, okay, or early on when you've been working on it for a year or two, you have quite a bit of knowledge, but it's still new. You're still kind of hunting and pecking a little bit. And when someone has a criticism that's reasonable, you have to step back, be introspective, and try to really solve it. And if it's wrong, then you have to prove why it's wrong. And if it's right, then you have to back up and fix it. And we did a lot more of that early on. Back to the stuttering thing, I think in some ways that's, kind of built me for that, because you get used to being laughed at as a stutterer, not in a bad way, but people do that. And so that's, in ways I look back as a gift. And so in some ways, I was able to probably stand my ground on those things easier, and not in a spiteful or narcissistic kind of way.
It's an armor you built.
And if you believe in something, if you believe that motion is really better, and back then, even hips, knees, hips were doing well, knees were still coming along, shoulders were still coming along, ankles weren't really coming along. But over these last 2 decades, we've continued to see those improve. And if you think of all synovial joints as one big S-curve, yeah, spine is one of the harder ones, and it's complicated because the disc is an arthrodial joint, and the 2 facets are synovial joints, and there's the spinal cord in the middle, and there's a joint on a joint on a joint there. But each joint, if you look at it, has complexities and challenges that the others, soft tissue coverage, balance, wear, all of that is different on joint to joint. But there is a lot of similarities. There's saying that things aren't exact, but they tend to rhyme. And that's a very valid point. So you have to be honest with yourself. You have to put the patient first. It was the first pilot was in South Africa. It was 2007. We still follow the first 2 patients. They're doing well. But that first patient, we'd be lying to say we all weren't really nervous. But we had done everything we could to make sure it was as safe as it could be. And then you have to believe, I do, that motion is better than fusion. And then you have to take, a well-calculated, thoughtful, moral, patient-centric approach, and go, kind of one little step at a time. But it's not been easy at times, for sure. You feel like you're getting an ulcer, you don't sleep. But that's just been part of it. So.
When did you start driving down that path? Because you said, you start to have this belief that motion is better, right? And a couple of years before that, you and Dr. Hodges were working on a cage, right? Like those are 2 vastly opposite spectrums. Did you have something in practice? Was it patient outcomes where you said, we need to try something new, especially when you look at a posterior approach? And like Courtney said, I think it was a great point on the topic of, it's not just you saying, oh, this is going to be a 20-year journey. It's how other people look at how you practice and your vision on practicing, right? Because that matters as well in practice.
Yeah, and I think spine is particularly tough, and I think fusion came out of instability. If somebody had a fracture, it was a better option than just staying in bed and letting it heal. You didn't get the bed sores, you didn't get the pulmonary problems, you didn't get DVTs, and then spondylolisthesis, and then it started to become more degenerative. And so as we got better at it and patients recovered better, the surgery was a little easier, and the indications started to expand. The hard thing about spine is you don't see people can function, like if you fuse a hip, it's pretty obvious that your hip's fused, or your knee, you either can sit or you can stand. It's pretty clear. With the spine, if you fuse one level, they often feel better, quite a bit better for a while. But then over time, you start to see breakdown at the adjacent levels or other issues occur. And particularly when you start to expand the fusion, the pressures don't go up linearly, they tend to go up algorithmically. And so I think kind of normally we've tried to improve. We've tried to make it better, recover better. We try to get the muscle envelope in better shape to protect the other levels. And all that's good. But at some point, you have to look at the other joints and you have to see that, the difference is still there. And, if we do a motion device, is it going to decrease the pressures on those adjacent levels? If we get to it a little earlier, which we don't really even talk about yet, but that's what happened with hips and knees, is the age started to go down because you didn't want to wear out your other joints. And so now, having a couple of decades behind us, we're seeing, real advances in innovation, but in some ways it's like trying to make a better horse and buggy, in that you're trying to make the buggy roll better and the horse run faster, but it's not the best answer. And that's where I think we are right now, is that we're trying to do fusions better and better, which is the intent of that is good. But the real answer is to replicate normal motion as best we can. And that's where we need to turn our focus. And unfortunately, you lose a little money along the way. It's costly early on. People have to take chances. And right now, I've heard you hear fusions keep the lights on, and that's a real issue. I don't mean that lightheartedly. There are people that work really hard that have jobs, and companies sometimes have to turn their ships slower because there's more considerations than that. But as a surgeon or a physician, our priority is the patient. And if there's better answers out there, then I think we need to strive, we need to go toward them, and we need to encourage others to do the same. And if we're wrong, then we're wrong. At this point, I don't believe trying to achieve normal motion, given everything I've seen, is wrong, though.
We were laughing because it's one of our favorite statements of if you ask somebody what they want, they can only answer with what's in front of them right now, right? That holds true for patients, that holds true for surgeons. So nobody's going to ask for a car until a car exists, right? You continually ask for a faster horse and, like you said, a better buggy when anyone would take a car, obviously.
You just need to be shown it.
Right.
Yeah.
But that doesn't happen without pioneers that are out in front of those things, willing to take arrows, willing to stand up for what they believe in. And I think the other side of it is just people don't realize the process that it takes, right?
Oh, goodness.
I mean, you talk about, this is a 20 plus year project. At any point, in a lot of different circumstances, technologies die off, right? And it's because
exactly
there aren't people that pick them up and move them forward, right? You talk about your story and all these little different inflection points, right? And it's guys like yourself, it's guys like Dr. Pat, and then Dr. Hodges, and then Mark Peterman shows up, right? And it's like, without each of those components kind of playing together, you don't get to the stage where you are. And now, you've got a company that's well-funded, that's through clinical trials, and now awaiting, FDA results and maturing data. But that doesn't happen without people picking up the torch and moving it down the road.
And we're by no means done either, right? We're having this conversation still and kind of in the soup in the middle of it. But it's really exciting to see how far it has come.
Yeah, and we definitely have much, much warmer responses. And it's, we're seeing now, and the patients are doing better. And we have 2 trials in South Africa, 1 big trial in the Cayman, and we just, as you know, have enrolled the FDA trial. The data's going to speak for itself. If you look back at hips and knees and stuff, there are times when it isn't perfect out of the gate, and that's one of the hard things is you're doing something for the first time, and people are expecting results that, from a safety perspective, which is not bad. I've gotten to really respect this FDA process and stuff. It's hard, it's arduous, it's they're very detail-oriented, which they should be. But you only kind of get that one shot. And with hips and knees, even Charlie, the first 300, the polyethylene he used, after 3 or 4 years, had problems and they had to replace them. The patients were still happy, and ultimately didn't mean a hip, replacement was the wrong idea. But you need to kind of push forward sometimes with things, and there's going to be little issues that occur. And, and to deny that or to say that there even shouldn't be is, I think, is kind of ridiculous when you're early on in something. You have to make it as safe as you can. Patients have to come first. Everything, there's no excuse for not preparing. But once you've done all that, you have to move forward, and there's always a little bit of risk.
Well, and I love too, you mentioned earlier that you still follow the first 2 patients, and you and Julie actually were just in Africa meeting with them 17 years later, just last year, which I think is phenomenal in itself, that there's still a personal connection to those families and how well they're doing. I'd love for you to kind of speak to that a little bit too, of going, you have this idea, you write it down at 3 a.m. on a piece of paper, and then you and Dr. Hodges kind of get to work, and you work hard to connect with Medtronic, who kind of starts to help support this and move it into a trial. And you go to have these first 2 patients in Africa. I can only imagine. I would not be sleeping at all. But I'd love to hear that story a little bit, and then to where you are today with those patients.
Yeah, and that story was, 2 years in, and again, we had hours and hours of meetings here. We had hours of meetings at Medtronics. We had hours of meetings with Pat about the appropriate ways to go through testing of materials, doing biomechanics testing, doing cadaveric testing, whether we should do animal studies. All of that was in place before we did that. And then we went down to do the first pilot, which was with Dr. Louis Nell. And again, and I need to mention somewhere in here that Mark was our first engineer, Mark Peterman, who's now our CEO now, and played a very big role in getting us organized and with the same work ethic that Mark's always had. Without him pushing us forward. And there were several other, Chris Hughes, Danny Braddock, there was several other engineers and stuff that played huge roles. Kyle Hess, I should put in there, just that really supported the whole program and actually went down for these initial cases. But the first two patients were, basically isolated single levels. Louis Nell is just an excellent, I don't want to say carpenter, but his dad was a neurosurgeon. He's probably done more motion devices than anybody I know, and potentially in the world. He's done a lot. And the first two patients actually got switched, which the second went first, the first went second, which still bothers the second patient because the first patient they always end up back at the same meeting in the same time. And the first patient always says he's glad he was the first, and they're a little competitive. So that's always a little bit humorous with them. But the first one was as a young guy who had L5S1, severe back pain. Didn't want effusions. His girlfriend, now wife, girlfriend at the time, was a nurse. And so Louis was just kind of watching him and then knew this device was coming. So he was our first patient. And he was a canine officer in the South African military, and he would guard the president. And I'm sure other people too. But he still is in the military, still has to do the training runs. He isn't a canine officer anymore, but still has to do shuttle runs and run. He has to ride 10 or 12 hours in a day over rough roads if you've been to, not all of them, but a lot of them in South Africa. And really his pain scores are zero. Now, it's not going to be like that all the time, but with him, some of it's his personality too, but he's just done phenomenal. The second one, Jaap, he wouldn't mind if I use his name. He's also a good friend of ours and his family. He's an off-road biker. He does... It's the name of the bike race down there. It's
oh my gosh, I know it too, and
It's a big race that's like 10 days through the mountains, and he's participated in it. I think he's actually won his age group, but 8 or 9 times. And the last time we were there, he and his wife had done a 4-day staged race, but he's still playing golf and able to participate in competitive mountain biking, which there is hard. And so, we most recently went down. They both have minimal pain scores, don't take anything other than occasional Advil, and have, really done phenomenally well. I think the other thing that's interesting, and it's not statistically significant, but when you look at the adjacent levels, they still have minimal arthritis, even at more than 15 years, which would be unusual, if not unheard of, for a fusion.
Well, it's, we were talking a little bit about the people that drive this forward, I think on the clinical side, right? Yourself, Dr. Pat, Mark, Scott.
The race is the Cape Epic.
The Cape Epic, there it is. I was going to say,
sorry.
Yes.
The true story is that it's an endurance race. Like it's a
1,000-mile race.
Oh my
endurance race.
Yes.
So the fact that he can get back and do those things is incredible. But the point that I was going to make is there's people on the clinical side that kind of push the flag forward, but there's also patients that have to take that first step, right? Because if you don't get those first patients that come in and say, essentially demand more, say, I want more out of my surgery, I want more out of my outcomes, we don't know where these technologies would be down the road. Like you need guys like these guys who step in front and say, I'm willing to test this thing out, and look where they are today, right?
And that's a good point. And I think it's, a point that I probably should say. We talk about Jaap and his Cape Epic, but if he told you what was most important, we talk about that because it's easy to visualize. But he couldn't hold his daughter, who was just born, was 1 or 2 years old. And he tells the story of his wife would be carrying the groceries and the daughter because his back was hurting so much. And people would look at him and say, what are you doing? And he just felt, and he's just a strong-willed, person that typically is very independent. He has his, own business. But it was that actually was the worst thing for him. He would have given, I'm putting words in his mouth now, but knowing Jaap, it was more about being dad and being husband and working with his team at work. And then the Cape Epic was important, but that probably wasn't, the primary thing for him. But yeah, both of them, we obviously did the consents, we went over it several times, and both of them had a good understanding. It was the first time. And now they're really proud of that. When we do publications and stuff, I can't say we send them every one, but we send them a lot, and we communicate with them, I don't know about every month, but many times a year, and know their families, let them know where the project is and stuff. And they feel a real, sense of contributing, to the well-being of hopefully many, many, many people to come.
How unique is that in this space, to almost 20 years later, still be in contact with the first two patients of a trial like this? Does that happen often? Is this a rare occurrence?
It's my first time in this level too. I would like to think it's rare. I mean, I don't know, but when, we kind of go through that. I mean, I remember not sleeping that night, and I remember everyone on the team, from Medtronics and Scott, none of us, our wives were down there for those first cases, and nobody slept. And then you're walking. So you get to know them on a level. And then when they get up, everyone's kind of like this, making sure, because even though you're worried, well, if their muscle tone isn't right, if they twist, they do a rotation, is that going to be and you're thinking of everything that could possibly happen. And then, they've got their Tasmanian devil shorts and they're just walking around, they're pretty, both the guys are pretty, a little cavalier, but they're strong character people. And so they're not fearful people. And that was helpful. And then they've just kind of taken off. We had no idea they could go over the handlebars and bounce down a mountain and be okay at the time, and stuff and most of them, we've seen that over and over in the study. And that's what, you don't want to overstate that. But, certainly people have given this thing trials at this point.
Yeah. In the pilot studies they have. Yeah.
Yeah.
It's amazing to see how that mindset has shifted over time as well, from those initial cases, just pure operating out of fear, right? Of like, we have this new idea, we think it's going to work, but you can test it as many times as you want until you put that into a patient. You don't know what's going to happen. And so it's amazing to see, 20 plus years later, how you look at those surgeries and how you look at kind of the outcomes of those surgeries as well. And just, there's such a different, right? We don't have that same feeling towards surgery now, right? Where you're scared. I mean, patients get discharged same day, a huge number. That's what we saw in Cayman, right? So it's almost this like huge dynamic shift. But you'd go back and you talk about some of these safety profiles and things like that, especially when you look at hips and knees. And the truth of the matter is, if we went back and you needed the safety profiles that you need now to get a device approved, hips wouldn't be around, right? And that's what I think that's a big today. Part, right? Yeah. And people don't realize that as well, is how much different that is when Charlie was going around. And, he has absolutely revolutionized motion care, right? And we need guys like that to walk so that we can run. But in today's age, how strict it's been, and for good reason, people don't realize how tight that is as well.
Yeah.
Or they forget that that's how it was at the beginning. I'd love for you to talk about that a little bit, because you are such a historian and you've written papers about Charlie, and you have that insight kind of, and like, remember, it was like this before. Can you talk to that?
A little. Let me start with the second series of stuff in Cayman or in South Africa. One of them was done in Cape Town, actually at the same hospital as Christian Bernard, who did the first heart transplant. And so that was since deceased or wasn't there, but talking to some of his colleagues, it was interesting to hear the stories, which had many parallels. But when you talk to Charlie, we went and visited Wrightington, which is a hospital in England, and Charlie, it was kind of perfect place, perfect time too. I mean, and perfect person. It was after World War II. A lot of patients still had TB. He was working in a military hospital initially, and then switched to Wrightington, which was an asylum hospital where people had TB and they'd recover in the fresh air and the sun and good food. But once they recovered, many of them would have just horrible arthritis secondary to the TB infections, and they'd be recovered. And that was really kind of the impetus. They were so painful, and he was doing a lot of fusions, but fusions would leave you with, a lot of restrictions for people who are relatively young, particularly with TB. And that was a lot of the impetus for him initially, to do that. And he was a pioneer. He not only, if you read, he not only made the hip prosthesis on lathes at the hospital, but he made theaters that with airflow. For example, airflow systems we have now kind of come down and the air goes out the bottom. Do you know where that came from? Any idea?
Well, it came from him. But I only know that because I read your paper.
Where did he get it? Where do you think he got that? He borrowed it from a lot of wheat and barley farmers in the area, and the workers would have to work with breathing the wheat and the chaff and the stuff in the barns. So they really created airflows that came from the top down, and he understood bacteria. And so basically he initially it was a little tented thing inside an OR. Now our whole ORs are designed that way. And then he designed it, the suits were the same way, which are basically the same airflow, which basically shunts it out the bottom. But, he was the first or one of the first to double glove. He was the first to do a materials testing machine. Actually, one of his engineers developed that. He had to come up with polyethylene, which was basically used in industry for hot like glass. It would actually, as glass came through an assembly line, it would bounce off the plastic which was polyethylene at the time. And so the other polyethylene that he used was fluorinated, and it would break down over time, over 3 or 4 years. It worked fine for a few years, but then would wear out. And he became very distraught about that. Imagine them replacing 300 people that you cared about. Most of the patients were happy because it was still such a better option than before. But still, he had to go back and replace a lot of them with the new polyethylene. And they tested it on a wear machine, the first one, to my knowledge, in existence.
I think one of my favorite pictures too is the image that you actually took of Dr. Charnley's operating book of the first total hip arthroplasty. Yes. It's when the inception of everything motion, right? It's so cool to go back to those. We talk about the early, MOTUS days or Kenai Device days of motion preservation in spine, but that was when things changed, right? Because people don't realize either we used to fuse hips and we used to fuse knees, and it sounds outrageous now, but that was standard of care at one point.
November 1962. But the other thing that was amazing, if you take a look at that book, is he did 2 hip fusions that morning before doing 2 hip arthroplasties in the afternoon. Now, he was doing all of them in about an hour. Now, hip fusion procedure is not easy to do right. And we should back up a minute. He also wrote one of the texts on compression and fusion. I mean, he understood doing fusions. He was one of the first, and then his book was well known for compression fusion. But to do those 4 cases in a day and being the first 2 had to be an exceptional surgeon. And, obviously he's passed away, but got to meet some of the people that worked with him. And, he demanded, he had a very high standard and sometimes could be a little ornery, as I understand it, but it was not only admired, but the people that you can tell the twinkle in their eye, they really cared for him too. So, and the hospital is very rural. When we walked in, there was a farmer's market going on in the lobby, so which was very funny. But it wasn't, it was a very laid back, country kind of hospital, which does a ton of joints. I don't want to make it at all sound unsophisticated. They've probably done more joints than anywhere. The people there are super, but it was just a very laid back, beautiful setting.
And this is one of the reasons that I was so excited to sit down with you, is just talking about this story of where we've come and where we've been, and that that goes with hips and that goes with knees and that goes with spine, just what it's looked like over time. But I think you hit on a really important topic too, of timing matters a lot, right? And the concept of fusions keep the lights on, that is true. We've heard it from multiple people, and that's not bad or good. That's just what the standard of care has been for a long, long time. And finally, we have new options, but things can only be successful at a certain time, right? There has to be so much research. There has to be guys like Dr. Pat that put 40 years of effort into these things. There need to be, engineers like Mark who jump on, surgeons like yourself and Dr. Hodges that jump on board. And it only happens at the right time, right? Because that's what's coming now. And we talk about fusion keeps the lights on, but at the same time, now reimbursement is starting to change, right? We're going to see how these things are changing over time, and it's almost all coming together at the right time, right? You're seeing more guys move towards endoscopic approaches. You're seeing more guys move towards motion preservation, but it's because they become comfortable with it over time, seeing these aspects, seeing how it changes, and then as the backside start to change, reimbursement, what patients are asking for, what hospitals are looking for. I think all those things need to come together for a device to get to where it is. And I think that's a big part of 3Spine's story as well, is the timing and where it is right now and where motion preservation is in spine.
Yeah, I think as you've said, as we've noted, these adjacent level breakdowns, and then they aren't all terrible, but a lot of them require more surgery. And I don't want to overstate it, because I think sometimes it gets to be this black and white thing, and that's just not my feeling. There's a gray, but I do think, if you look back again at history, that 50, 60% success rate in 5 years or so just isn't good enough. And we saw it, we see better than 90% in hips. We're seeing that now in knees. We're seeing that close to that in shoulders. Ankles not quite there, but certainly on its way. And I think the pushback from insurers that, and when you do it, you need another surgery that costs more. It takes the patient out of work. Patients don't want a fusion. I mean, most physicians don't want a fusion. Most orthopedic spine surgeons or neurospine surgeons don't want a fusion, right? I mean, let's be honest. And nobody wants a big surgery, but I'd much rather have a hip replacement than a hip fusion. I would do that earlier. I would consent to that with a lot less trepidation, or knee. And I think the same thing's true. You see the response we had even in the study was, I mean, the number of calls we got when we had to stop doing the side of the procedure, people were mad because they couldn't get into that side of and I think we probably enrolled that study about as fast as anybody. Not that we were hurrying, but it was just there was a demand. And that was without, I mean, we did some local advertising and stuff to support the surgeons, but not over the top. And so we're seeing internal med docs don't really like to refer, you know, family practice docs don't like to. Family members tell you not to do it. People who've had bad fusions tell you not to do it. And we're just seeing that slowly build. And so I think, you know, as it happens, it's kind of it'll be gradual until it isn't. And then it'll probably happen pretty quickly, like with the other joints. And I think it's going to take the young, you know, we have a lot of super smart, as you both know, young, you know, you've already had some of them on the podcast. I'm sure others you're going to. You know, I think Scott would say the same. I'm not sure either of us feel like we could even get into a spine fellowship now because these guys are so smart. But that's who, you know, it's this next generation. I mean, you know, you just listened to the names of the people's shoulders that we've stood on, and that's a fraction of the people that have made a difference for us and, you know, believed. And I think, you know, these guys are going to, you know, hopefully take the little bit we added to everything below us and take it the next little bit, just carry the flag. And I think that's the part of medicine we often don't talk about too much.
Well, part of it's what's available too, right? I mean, you even talked about Charnley is that he knew fusion really, really well prior to doing total hip arthroplasty, right? Yeah. It's the same as what we see right now is like the younger guys, it's because they're training with these options available. These options weren't available 15 or 20 years ago. And I think that's part of the problem too, is that they just weren't there, but now they are, right? So they will grow up utilizing these things when they're in residency, when they're in fellowship, whereas never seeing these, never hearing about research from, I think that makes a big difference as well. It's just what's available.
Yeah, and I think there's been some fragmentation too. I will tell you that, you know, spine surgeons or orthopedists have moved away from the AAOS. It's not that it's a bad meeting. We just don't go. There's too many meetings and you just can't get to there. And neurosurgeons never went because they're not orthopedic surgeons. So there's some fragmentation of the group of spine surgeons is not really, you know, getting the history of knees and hips and ankles and shoulders like we were when we were all part of the AAOS. The other thing is semantics. I think that's really made it confusing for people is that we say disc replacement like it's a hip replacement. And the disc is an arthrodial joint. You can take the disc out and it's stable without putting anything back in there. That's not taking anything away from lumbar disc or cervical disc. I think they both have just with the right indication are a good thing. But when you take, you know, the proximal femur out or the top and the bottom of the knee, the distal femur and the proximal tibia, you're making an unstable joint, which is the same thing you're doing when you take both facets and the, you know, out, is it's unstable until you retension the soft tissues appropriately, balance it appropriately so that they can then function more normally. But that's the only way you get to a normal joint is if it's moving across all three columns, which goes back to a lot of the stuff we've done.
Really quickly, just for those who are maybe listening to this podcast for the first time and they're like, well, what is MOTUS? And like, what are they talking about? Can you explain what MOTUS is and kind of that comparison that you were just doing of like, we say MOTUS is the first total joint replacement for the lumbar spine, but then there's a disc replacement. Like, what's the difference between those two?
Yeah, that's a great question. Each segment of the spine, so, you know, let's talk about the lumbar spine specifically, there are typically 5 segments. And we tend to, surgeons and healthcare workers who work in spine tend to think of them as motion segments. So it's really one vertebra that's moving on the other. Now, it's more complicated than that because there's one on the other. And as you mentioned, it's even more complicated on that when you start taking hip and knee and ankle because all those joints really work together. And we don't talk about that because to stand upright and to do our daily activities, pretty much all the joints. And I don't want to get off into AI and stuff that can look at a lot of data at once, but that's not that far away, and that's going to be helpful, I think. But for each Mosen segment, there's a place where it naturally teeter-totters, right? Because mostly of the lumbar spine, it's a flexion. Most of your stuff, we call it the sagittal plane, but it's really this flexion plane. That's where you live most of your life, is being able to pick things up. And for your low back, it's a lot of it's kind of the heavy work stuff. And so once that gets degenerative and starts to hurt, then it either needs to be fused. I mean, that's, you just assume that we've exhausted all conservative care for the purpose of this discussion. And at that point, you can either fuse it to stabilize it, and one thing different about the spine a little bit is that with a hip, you're just taking off arthritic joint, but with a spine, you may actually be having a nerve pinched or things called stenosis. So not only do you have to prepare it for either a fusion or a motion device, but first you have to even sometimes take off more bone to get rid of the pathology or part of the reason that the patient was hurting. So if they're having terrible leg pain because of a herniated disc or they have a cyst hitting on a nerve, you have to do that first. That's your neurosurgical or orthopedic surgical hat, getting rid of the pain. Once it's done, if it's still stable, then you're done with the procedure. The patient can get up and walk around. If it's not, or you think it might, be a problem, then you have to stabilize it. And the only way to stabilize it right now, really, in that setting, is a fusion. And that's, the fracture is kind of the same thing. It's an unstable segment. But this device allows you to stabilize it, but instead of fusing it, it allows it to move. And really, if you think of, putting something between the two vertebrae that are now unstable, and then it basically all grows together. The motion device isn't really that different. You slide it in there, the top vertebra fuses to the top of the motion device, the bottom vertebra fuses to the bottom of the motion device, but instead of being one solid structure, it's got a little hump like a teeter-totter, and it teeter-totters back and forth. So it's still constrained by the fact that it's growing into the bone, the polyethylene's in the disc. It's just allowing it to move back and forth, and built into that device is you stretch it back into the soft tissues, just like our hip or a knee, and that gives it some stability. And then to shear, which is, forces this way, that little ball, the balls bilaterally won't allow it to do that. And so it's not, now enough force can do anything, whether it's your own back or anything. If you're in an 80-mile-an-hour car accident, whether you have a Modus device or your own back, it could fracture. But we've seen with normal activities and even excessive activities, it's been very stable so far.
I have to say, I'm really impressed with your hand movements.
Sorry,
of being
was
able
that too
to,
much?
No, it was
I'm
great.
thinking it's in the mic. I'm
I'm
not supposed to touch the
envisioning a
mic.
model as you're doing it. I'm like, wow, he's actually doing a really good job at that. We should have brought him a model.
Yeah, I should have brought it. It's on my desk. But
Can you talk about, too, the importance? Because one of the biggest differences about Modus is a posterior approach motion device, because we have a lot of anterior approaches, both cervical and lumbar. Can you talk about the importance of having a posterior approach device that also preserves motion?
And what's the difference between those two?
well, first of all, an anterior approach, you go through the abdominal cavity. We're talking about the lumbar spine. And a posterior one, we basically divide the muscles in the back. Because the spinal cord sits on the back, or the nerves and stuff are on the back, it makes it difficult from the front because you got to work all the way through the bony skeleton, and you can't see very well because you're kind of looking through a narrow passage. Some of the structures in the front too, the big vessels and stuff, if there's a problem, it can have a higher risk. Now, in fairness, people who are used to doing anterior approaches and stuff have a pretty good results with that. And so sometimes I think that can be a little bogus and revisions can be hard, but people who do it all the time, tend to do pretty well at it. But coming from the front, you can only replace that arthrodial, only the disc. You can't do a total joint replacement. You can't get to the facets that are in the back. So if your facets are healthy in the back, that's the two little joints in the back, then that disc replacement can be a decent option, or a fusion in the front. But it's limited. Again, that's why we struggled with it, is that we thought the indications of that were limited, because most of the time when people need surgery, they're having leg pain or back pain or instability where it's shifting, which is the vast majority of patients. And that you can approach better from the back, because when you come in, the nerves are closer to you. And when you lift off either ligament or bone, you can get to those and clean out, whether it's ligament or disc or spurs or whatever's around the nerve that's causing the pain. It's easier to clean that out and do that approach. So most procedures are done from the back.
And how often is it just a disc that is having issues versus the facet joints?
It's usually a combination of things. And, I was talking to a patient today. I had a real, it's a spouse of one of our docs, and he has a complex herniation with a weak foot, and very athletic guy. Everyone's so different. I mean, it's hard to really, most of the time a disc herniation alone is not going to need a fusion or not going to need it. But large central disc, recurrent disc, people who just have back pain do exist, and it can be discogenic. Now, you don't want to. It's easy to overtreat that. Is one of the worries, but there are those patients that do exist. I would say many of them include the disc and the facet. Most of the time, when you have to do a replacement, it's either unstable, and our device is only for grade 1 spondylolisthesis and down, and hopefully over time the design improvements will allow other ones to be treated. But so most of the time it's an iatrogenic destabilization where it's either going to cause pain if you don't do something, or you have to do so much decompression that you feel like the patient may be unstable or is at risk for it moving and then requiring further surgery. And it's many of the same cases that we just fuse today, especially with the 1 and 2 level kind of things.
So we talked a lot about your role and impact at 3Spine and on Modus and the project as a whole over the last 20 years. But what I really want to wrap up on is the end of your personal journey and what it's been for you the last 10 years and the mission work and the philanthropy that you've worked on. I think a lot of that started, if I'm correct, when you kind of made the shift back to Alaska from Chattanooga. Can you talk a little bit about that story and then kind of what has progressed from there since you've moved back here?
Sure. Working with more, underserved communities has always been kind of a passion given the background here and service. And, I was in Chattanooga 15 years, as you talked about, and it was great. And we had access to Medtronics. We were in Chattanooga, Spine Medtronics in Memphis. Scott and I would drive over every other week for years, working on the projects. And we did a lot of research stuff there, which was great. And the project, like I say, started there in 2002 and continues till today. But after 15 years, I was, just getting ready to turn 50 or just before 50. We were already thinking about it seriously, about moving back. Julie and the kids, we come up here to Alaska every summer. It's more of a rural outreach. I had wanted to do more mission kind of work too. And one thing that I hadn't mentioned to you all is, as we were, kind of in the thick of planning it, I had a bilateral pulmonary embolism and ended up in the hospital, 4 or 5 days, but literally couldn't walk from, 5 or 8 feet, just a massive, I was white out in one lung and multiple PEs on the other side. I just didn't know I was having them until I got so short of breath. And so that kind of makes you think, and I don't want to overstate it and overly dramatic. But we were already kind of on a path of, we're going to be 50, I'm going to be 50, I'm a little older than my wife. And we haven't done some of the things that I went into medicine to do. One was rural medicine, kind of underserved. So we decided to come back to Alaska. I was off, I was initially going to go to Anchorage, but then, I'd grown up in a smaller community that was starting a hospital, wanted to start a spine program. And I was, hopefully it would give me the ability to work in either the bush communities here or elsewhere. So kind of painful for the family, kids a lot of them were in school, and it ultimately ended up being a good thing. But, there were some tears, and, one of my daughters didn't talk to me for a while. And we're very close, always have been, still are. It was a hard transition. In hindsight, sometimes you need those kind of things, but, it ended up being kind of better for everybody, even though, we miss a lot about Chattanooga, in particular our friends there. But coming here allowed us to kind of reset, and we started a program here, first O-arm in the state. So we had a lot of new tech that came here. A lot of people that would normally have to fly to the West Coast were able to receive their care here. And it kind of gave us a little bit of a blueprint about setting up something in a rural setting, even though the hospital is very modern, very new. But pretty quickly, I got befriended one of the general surgeons here who did work in Kenya. And I just went with him on a trip. He helped him with some thyroids. We ended up doing a couple of spine cases in real rural Kenya, up near the Uganda border. But while I was there, I went and visited a couple of the other cure hospitals and AIC, which is African International Hospitals, and decided to come back about 6 months later. And over the course of a couple of trips that were challenging, to say the least, I almost quit after the second trip. Thought I wasn't going to quit mission stuff, but going to go somewhere else. But fortunately, at the very end of that trip, I met a Dr. Joseph Thiori at Cure Kenya in Kajabe, which is a little town outside of Nairobi on the Rift Valley. And they do predominantly kids with the deformities. And he and I, kind of matched personality-wise and have since become, really good friends. And that was about 11 years ago now. We've been going back and forth, and we've built a residence for visiting medical staff. We're working with Cure as the educational component to teach spine. We just did the first first O-arm case in the area. We had an O-arm Stealth, a refurbished one. It was donated by Medtronics. Thank you, Medtronics. And, it's just been a privilege to be able to take care of the kids there, get to know the families. And again, you go over with the intent to try to do what you can, but it takes a family. And, we've gotten to know the Kenyan surgeons, a lot of the people in industry, Stryker, Medtronic, Spineart, have helped a ton. And without many, many, many people, it would be impossible. But now we're hopeful to have a training program there that outlives the rest of us, that'll allow Kenyans and Ethiopians and people in East Africa to take care of people in East Africa. And that's the ultimate goal.
Can you talk about the name of your foundation and the importance of that and how it really connects back to, what you knew as a child that you wanted to do?
Yeah, it's called Carolyn Jane Foundation, which is after my mom, who did a lot of work with the kids here that were, kind of didn't have the same chances as some of the other kids, just because of the backgrounds, and just trying to help them, come into the educational system so that they could learn whatever they needed to learn for whatever, come in and be successful. Because if kids get too far behind at an early age, then it can be hard. And if value systems are different, in families, if school isn't as important, then it can be really tough for kids. And that's tough because you're trying to navigate different cultures, their values. You're trying not to change their values, make them feel the importance of their own values, but also, things that might help all of us to move into the future. And those are hard and sometimes very stressful topics, that aren't easy. But if they're ignored, I think it's even worse, so you have to try to do the best you can. And so I watched, I had very strong, both my parents were very different, very complimentary, but my mom was very strong, but always very fair. And she, felt that, you should treat somebody cleaning the floors just like you should treat the president, at least initially, and if, somebody's dishonest and fools you a couple times, then you obviously can change your opinion and you have, but you treat everyone respectfully. It was a big, both my mom and dad. And so, those kind of models, I think, kind of helped me. And so we kind of came back and, it is about my mom, but I think it's kind of about it was initially intended to be about all teachers and, that kind of feel. And I think physicians in a lot of ways are teachers too. And so that's where the name kind of came from. Seemed like a natural fit. And
that's a big family initiative. Julie, your wife, is very involved as well.
Yeah.
I think we were talking, you guys have gone 5 times this year.
Yeah. She spent the better part of last year in Kenya while the house was being built, because trying to do something in a different country. And it wasn't George Putnam, who's one of the guys that runs a lot of the Cell Saver and monitoring, has started a scholarship program there to train. He works with a pediatric cardiac center there in Nairobi, develops heart-lung and the Cell Saver machines for that. So we've been involved a lot. And it's kind of, again, just kind of one step leads to something else. And you look back and you're sometimes amazed because we really didn't have some master plan. We went over just to help. And we got to, feel like family with a lot of people in the community. And then when you sit down and are talking about it after a few years, you say, well, what can we do to kind of make this a little better? And it's like, well, we need a place to live, and when people come over, they're comfortable and we can do the logistics so they're not nervous when they land and help them with their immunizations and licensing. And so when they come with their team, it's comfortable. We have the cases ready. We can help follow it up. The fellows understand, what they're doing. They'll have help. The instrumentation is the best we can, so the lighting could be the best we can. And I think at that point, then we start getting people, which we've seen already, we're getting people there that it's easier for them. It's not as big of a jump, and then they can come and give their expertise and their talents and their insight, to people that are like ready to suck it up, and then, to just like sponges. And then there's, 500 million, 800 million people. If you look at Somalia, Ethiopia, South Sudan, Uganda, Congo, all those countries are short on help, particularly for kids. And so just a little bit can go a long way. And so, we're trying to get this into a place where people can come, long after us and teach and make East Africa part of our, our world medical team, or however you want to look at it, world medical family.
It's been 11 years since you and Julie co-founded the Carolyn Jane Foundation. And I think one of the things that it stands out so much to me is the different pillars that you have involved in it. And so obviously there's a sustainability aspect to it. It's not just going there, throwing care on people and then not having people to provide follow-up care or the technology that they need or the training that they need. I think one of the things that you guys have done so well is creating this kind of multifactorial pillars of care, right? So not only are you guys going there to provide your own time and your own resources, but you're training staff that are on the ground, right? So clinical resources, getting them the technologies that they need, building housing, right? You guys broke ground on housing in 2022, and now having a fellowship program as well to have long-term sustainability for some of this, because it doesn't work if it's just a one-off providing care, right?
Yeah, that's very appreciated, and a lot of people go for a week or two, and that's wonderful. The logistics are hard, but after having done that for a few years, we thought, what can we do better to take care of more kids? And the truth is, we know a lot, and with the techniques, and we can share that, and before long they pick that up. But they know their own communities, they know their own social groups, their own country, their language. They know and so it's easier for them to take, and they have their own ways of doing things. That you also have to say, okay, that's not the way we do it, but it works here, and it's given. It's inside the system that they have. You're not going to change their whole system, which I've learned more than I've given by far, and I would say we come away feeling more blessed than we actually contribute. But I think the one thing we can say is just by staying with it, not just me, but the Kenya family and just being there day in and day out allows the program, to kind of move forward. And there's all kinds of people from Stryker, Medtronic, Spine Art who have a heart for this too. And, like I say in the background, that have just been incredibly generous, and not only with materials, but just emotional support and encouragement. I think we've mentioned it now the third time. There's a lot of times in your life that people believe in you more than you do yourself. And, that's the time when they kind of carry you from one puddle over the puddle until you get your feet back on the ground. So there's times you want to stop for sure, but in hindsight, you see these kids, you get to know the families, you see the difference it makes, you see them go on to be pilots or artists or whatever it is, and there's a lot they can do in Kenya, but it's hard there. They worry about food every day. They dream about maybe having a motorcycle one day. Their housing's often dirt floors, no heat, no lights. Most of us would have a hard time surviving, and yet they do it with a smile, and are great. And I would say the average Kenyan's probably happier than the average American sometimes. So we have a lot to learn too, I think, about things and how they don't really make us happier always. So without getting too philosophical, but
no, it's true. And I think, kind of to wrap this up, and I think it just shows exactly who you are, Modus, and your idea of, coming up with that and saying, I want to push forward and I want, better care for people. I know that there's like a feeling Kenya and Carolyn Jane and Modus like all come together for you. It comes from the same place in your heart of providing more. So I'd love to hear a little bit about that as well.
I would like to say the whole team supports this, including you guys and Mark, is that I do believe technology allows us to lower pricing on things. And so as materials improve, and we've talked a little bit about AI and robotics and stuff, that cost will come down. And I think materials will allow us to do motion there at a much lower cost. Like the refurbished O-arms that they often don't see, by getting it over there. If nothing else, it still works great. We just did the first O-arm cases last week over there on 3 tough deformity cases. But they learn the technology. It's not just about having it. It's about not getting further behind, because now in our modern systems, we're seeing robotics accelerate, we're seeing AI accelerate, we're seeing imaging accelerate, we're seeing materials accelerate. And so there's a bigger and bigger gap forming over the underdeveloped. And so just keeping them up on stuff and potentially getting a robot, or a refurbished robot in a few years allows them to stay put until these costs and stuff come down. And they will. They made the jump, when we used to have power lines and stuff here, we couldn't do it, but they all made the jump right to cell phones, which is a powerful instrument, or an iPad, and it's so much less expensive. And the same thing will happen in medicine, but we just have to keep them connected. And, I think there's, we're in a really exciting time. I hate being old, because I would love to see the next 20 years are going to be so exciting about, with tech coming, and that tech can help our countries and help our patients, but we can't forget about the other 30 or 40%, because it can make a massive difference for them as well. So I think as physicians, that's, part of our responsibility. So.
Well, to push forward meaningful change, it takes an army, right? It's true across everything that we've talked about today. Carolyn Jane Foundation has such a big impact, but it's not because it's just you, right? It's you, and it's Julie, and it's your family who's buying in, and it's vendors who are helping out, and it's people on the ground, right? It's the same with Modus, right? Like Modus wasn't born or created by a single person and pushed forward. It's everybody. And Modus wouldn't be around if it wasn't for all the work of the motion companies prior to that, doing all the work and laying the groundwork, right? But to make that meaningful impact, it takes an army. And I think that's one thing that we resonate, and we have, we're very fortunate to be here with you and just to get to know you guys over time. It's not a one-man show, right? Everything is done through the creation and the help and the support of the people around.
Yeah, and I think both with Modus and Carolyn Jane, I mean, I feel, sometimes when you're talking about it, it takes on the illusion that it's, I have a bigger role than I do. My role is pretty narrow. I go to surgery and come back, and there are 15 or 20 or 30 people who are totally building the house and totally doing the logistics and totally getting all the instrumentation and keeping track of it, and people at the companies who are supporting us and getting things. I mean, I'm like a 2%er in the whole thing, and I just am one of the spokespeople. But as you say, with everything else, it's eventually I'll be somewhere retired, and few people will remember your name maybe, but it's going to be the next 50 people moving it on. We're just kind of we're fortunate to be in that continuum with people that I admire and have helped move us along. But don't think of yourself too lofty, and on the other hand, don't think of yourself too down. But I think those are kind of good things that we hear is don't put yourself too high up, but don't beat yourself up too much either. But that's kind of a good way to stay, because it's pretty true. So
I don't think these different aspects, these different accomplishments, they also don't happen by accident, right? A lot of it is the people that you surround yourself with. And so there have been a lot of different components that have helped out to drive a lot of these different aspects forward. But it's because the people you surround yourself with, right? When you've got a wife that supports you and works as well as she does and has the same beliefs and passion that you do, same as the people that you work with, right? Whether it's, a surgeon in the room or industry, you want to have the same passions, you want to have the same beliefs, but it's those people that you surround yourself with to be able to push those same things forward.
No, absolutely. Everybody brings, and I would just say my wife probably even has more when I see her up with the kids, or they're singing in the afternoons or coloring at the ward. I mean, she's often up there later than I am till 9 or 10, not just her, but many members of the team. And that motivates you too. You come home, you're tired, your feet hurt. And then you see them still up there, you put your scrubs back out, you go do night round. I mean, everybody motivates everybody, and everyone has a role. But there are times, like, say when people help you and you help them, but you're with the right people that are all kind of moving forward no matter what. So, I think people are purpose driven. I think we need a purpose. And that can be combined with spirituality, or, some people make their goals more monetary or those kind of things. And I always wonder, it's kind of hard to find the same meaning out of collecting things or doing things. And everyone finds their own path. But I think if you can find something that means a lot to you and really, hopefully does some good, it's a good way to live a life, and then to look back on it and feel like you donated something or given a little something.
We certainly can't downplay our appreciation for you guys to host us here for this weekend. The relationship that we've had with you guys over the last multiple years here, I mean, it means a lot to us to be back at this place where a lot of it started as well.
For us to get to see this place.
It is. Yeah. It's incredible, right?
Yeah.
And we've talked about so many different things, but just the passion behind both you and Julie, and obviously you guys have 3 great kids as well. Like, all those things don't happen by accident, but it's a testament to you guys. It's not that you guys have plenty of free time and are sitting around wondering, what are we going to do next, right? I mean, you're doing all these things on top of your practice, on top of seeing your kids and raising great kids, on top of, everything you guys have going on out here in Alaska. And it's not exactly a quick journey either, right? So to be able to be back at the place where I think a lot of these things started, when we talk about Modus, when we talk about Carolyn Jane, I don't want that to be lost, because it means a lot to us to be here with you today. So.
Well, thank you. I appreciate making the trip, and it's been a pleasant conversation, hopefully informative.
I think the best way to end this would be to hear the story of why this is such a special place, why the river behind us means something, and kind of that the magic that started here.
When we first moved up here in 1969, I mean, it hadn't been a state that long, 10 years, you think so. Yeah, and my dad came up in 55 before it was a state. So, but we started coming down here probably in the early 70s, fishing in a campground not far, and we had a little camper. And then eventually, these lots came up for sale, and I think this lot was $11,000, which was a lot for my parents. I think it took them like 7 years to pay it off. But we camped down here, and all the same. There's like 8 lots that way and 3 lots this way, and all the same families to this day still own them or their kids still own the lots. And so we've just kind of grown up down here with with the same older folks that have known me since I was 8 or 10. So, and then this house and stuff, was the logs were cut down in one of the federal forests when they were beetle killed. They were dead, but dried standing, and so they were cut. And we moved them down, and we had a person help us make the logs, which is unusual to have a 45-degree slant with a coped log. It's a Swedish cope. And it's just been a 50-year process, kind of building these log homes. Are hard. I don't know if I do it again, but they're pretty and they're warm. Yeah. But I think more than anything, it's just the memories of putting it together, or fixing stuff with my dad, or putting the deck in, which is I never thought I'd end up living back here. But it's just kind of full circle. Kind of feel like a salmon coming back after all these times. But yeah, it's where the Kenai came from. The original name, as you know, was Kenai, not named by me. I can't remember if it was Scott or Chris or one of the original guys we had in time when we named it. But it was switched to Modus sometime later. But some of the original articles are named after the river or Kenai.
Kenai Device, yeah. Mm-hmm. Right behind you that you get to see every day.
Yeah, which is nice. This is kind of a special place, and it's a good place to relax and think. That is one of the things that the mountains and stuff have a way of, when you can get out and away from everything, it's definitely calming. So
it's incredible. I mean, again, we're so fortunate to be here. For the people that have heard this and are starting to hear about it for the first time, whether it's Caroline Jane Foundation or your own practice, where can people find you?
Probably email or 3spine.com would be probably a good place for this. Is just reach out to my email there or to 3spine, and they will connect me with you, or email me and I can get back to you, whether it's clinical or it depends on what it has to do with. If it's Carolyn Jane, you can look up Carolyn Jane Foundation too. Yeah.
You guys have, you're on all the socials. You have a website, so they can find you there. And I'll put it in the description as well, so people can get involved if they want.
That'd be great.
And then your practice as well as CraigHumphreysMD.com for people that are looking for care in the area. So.
Yes.
We'll help you out.
Yes,
there.
yeah. We're going to yes.
It's so funny. Every time we ask this to a surgeon, they're like, I don't know. Like, we've heard Google me so many times.
We're just trying to get people to the right places. Well, we can't be more thankful to you guys. So thank you for hosting us. Thank you for doing everything. It means so much to us to be here. So we appreciate it so much.
I appreciate you guys. Thanks.
Absolutely. Thanks.
Yeah.